It's 29 minutes past the hour. Are we getting ready in a moment?
Let's start right at 9:30. Welcome. My name is Chris McLaughlin, and I am with Integrity Continuing Education. Thank you for attending today's CME program, targeting upstream mediators and the airway epithelium with next-generation biologics. Before we begin, I have a few housekeeping notes I'd like to review. For your participation in tonight's program, you are able to receive up to 1 AMA PRA Category 1 CME credit. To do so, you must complete the post-test and evaluation that will be distributed at the end of the program. Your certificate will be emailed to you within 4 weeks of receipt of your completed evaluation form. The link to the downloadable resource guide was provided to you in the reminder email sent out earlier today and is also posted in the chat. We encourage you to engage in today's program and contribute your knowledge to the activity. At this time, I am pleased to hand the program over to our faculty presenters, Dr. Michael Blaiss and Dr. Michael Wechsler.
Thank you, Chris, and good morning, everyone. Thanks for joining us. I am Dr. Michael Blaiss. I'm a clinical professor at the Medical College of Georgia at Augusta University in Augusta, Georgia. And Mike, would you like to introduce yourself?
Absolutely. It's great to be here this morning. I'm Mike Wechsler. I'm a professor of medicine and director of the National Jewish Cohen Family Asthma Institute in Denver, Colorado. And I'm also a pulmonologist, while Mike is... Mike?
Yep, I'm an allergist.
There we go. Great to have you today and looking forward to an exciting program.
Great. So let's look at our faculty disclosures. And we have 3 learning objectives for you today. One is we're going to describe the unmet needs with current severe asthma therapies and the contributions of the airway epithelium and hyperresponsiveness in the disease. Next, we'll explain the involvement of alarmins in severe asthma and the rationale of targeting upstream cytokines in controlling the disease. And very importantly, we'll learn to apply the newly approved treatments that address the alarmin pathway in severe asthma in appropriate patient types. So Mike, why are these objectives, these learning objectives I just covered, why are they important for us?
Well, these are really exciting times in the management of asthma. First of all, asthma continues to be a big problem globally and certainly nationally, with over 25 million people suffering from asthma. And our knowledge of asthma pathophysiology is evolving so quickly over the last several years. We've gained a huge amount of information and knowledge about asthma, about its pathophysiology, and we're also gaining information about new strategies to treat asthma. And one of the key concepts that we're going to be discussing today is the newer concepts of the role of the epithelium and how the epithelium generates specific alarmins, epithelial cytokines that can play an important role in asthma. So I think it's critical for clinicians to get a good understanding, because getting a good understanding will allow us to better take care of our patients with severe asthma, particularly in the context of the newly available therapies that are emerging for the treatment of asthma that target the epithelium, targeting airway hyperresponsiveness, targeting these epithelial cytokines.
Yeah, I think, we're really living in a wonderful age related to asthma. And as we've seen basically over, say, the last 15 years with the development of biologics and our better understanding of type 2 disease. And now, very importantly, looking upstream, looking at the epithelial alarmins and how they can play a vital role as far as targets to help control so many of our patients that are suffering with severe uncontrolled asthma. So I totally agree. So what should you expect today from this program? One is we're going to give you an overview of severe asthma therapies and how the airway epithelium and upstream mediators come into play. We have 2 interactive cases for you that we want you to participate in today, and you'll be able to respond to the program questions that will open up in a Zoom window when we get there. And we'll discuss the decision options of this case study. And for you to contribute to the discussion, you can use the Zoom chat function and send messages to us, or to come on and speak and go to the reaction button located at the bottom of the Zoom window and raise your hand. And as mentioned, you'll get a take-home resource guide that will be sent after the program to your email. So again, when we get to the cases, we really do want your input. So with that, I want to start with the current therapeutic approaches to severe asthma and the unmet needs of therapy. And I'm sure most of you are very familiar with the GINA guidelines that are updated yearly, the Global Initiative in Asthma. This comes from the latest update from just a few months ago, GINA 2022. And here we're looking at a GINA decision tree for difficult to treat and severe asthma in both the adult and pediatric population. And you'll notice over to the left, it talks about assessing the severe asthma phenotype and factors contributing to symptoms and quality of life and exacerbation, and talks about, again, adding a type 2 targeted biologic in those patients that are under poor control, that still continue to have significant exacerbations, even though they're on high-dose inhaled corticosteroid and long-acting beta agonists. Now, very importantly, it talks about local payer eligibility criteria, because we know that, in fact, all of these treatments, though efficacious, are definitely costly, and also talks about things like dosing, frequency, route of administration, and patient preference, which really gets into, and we'll get this with our cases, gets into the role of shared decision-making in our patients with severe uncontrolled asthma. So then it talks about which biologic is appropriate to start with. And you can see the eligibility for the different classes here, which basically, as we know, comes from the package insert for each of these products, whether we talk about anti-IgE or the anti-IL-5 agents or anti-IL-4 receptor agents or anti-TSLP. Very importantly, over on the right, you can see the predictors for asthma response. And these can help us as far as possibly determining which biologic may be best for which particular patient. So you can see here as far as what factors may predict good asthma response. First, for anti-IgE, the increase in blood eosinophils and ENO, allergen-driven symptoms, childhood onset asthma. We look at the anti-IL-5 agents, the higher blood eosinophils and more exacerbations than previous year, adult onset asthma, nasal polyposis, and for both the anti-IL-4 receptor agent and for anti-TSLP, you can see here that predict response tend to be higher blood eos and higher exhaled nitric oxide. Now, what is clear is that it has made a great deal of difference as far as the biologics that we have had over the last several years. And this study by Minnie's gal looked at the real-world use of the traditional biologic therapies, looking at 2 registries. One was the Severe Asthma Registry, and another based in the US Chronicle Study. And what you'll notice here is about 80% continued the first biologic. Now, that doesn't mean that they were under absolute control, because in fact, data has shown that's not necessarily true, but about 79% did not change biologics. 10% or so stopped biologic entirely, did not go on another one, and almost 11% did switch biologics. When there was a switch, the most common was from omalizumab to one of the anti-IL-5s. Again, remember, these have been around the longest. And then the next most common subsequent switch was between the anti-IL-5s. Now, as we would surmise, the most common reason for switching biologics is insufficient efficacy, and at least in some of these patients, it was adverse events. If you look at just the US Chronicle study, greater than 90% again continued their first biologic. But if you look at that data, really less than half did not have a significant exacerbation in that first year on the biologic. But can we do better? And I think the answer is absolutely true, because we still have lots of patients that are using a great deal of oral corticosteroids. And as we know, not all our patients are type 2 high disease. So over on the left, if we look at the bar graph, the first study comes from Tran, where about a quarter of the patients with GINA 4 and 5 were high oral corticosteroid users. So these were patients that were followed retrospectively for approximately 2 years, and they were classified as having high OCS use if they used more than 450 milligrams of prednisone within a 90-day period. So you can see here that that was almost a quarter of the patients. And then one of the things we know is that about half the patients we take care of, in fact, do not have type 2 high disease, but are type 2 low. And if we use transcriptome analysis, that number, in fact, is even higher. So there are a lot of patients that, at least until recently, we haven't had treatments for, especially for type 2 low disease. So, Mike, this comes to our next question. What are the current unmet needs in severe asthma?
Well, as I mentioned, there's still a lot of patients with asthma, and we continue to have a lot of unmet needs. There are still a lot of patients who are oral corticosteroid dependent, and I think that's an important issue because of all the side effects of corticosteroids: cataract, glaucoma, osteoporosis. And then there continue to be patients who have exacerbations despite being on biologics. And so why is it that we can do pretty well with a lot of these therapies? We'll reduce exacerbations by 50% or more, but yet there's still a large number of patients who continue to have exacerbations or who have exacerbations that remain untreated. Part of those exacerbations are due to factors that are non-type 2 related. And I think that's one of the areas where we really have not seen good results from the newly developed biologic therapies. So non-type 2 disease has been really underserved, I would say. We've got good therapies for patients with eosinophilic asthma, the anti-IL-5s, anti-IL-4/13s, good therapies for patients with allergic asthma. But for patients who've got non-type 2 disease, that's really where I think we have been underperforming. Bronchial thermoplasty and azithromycin have been relatively effective, but I think we could do better. And as you mentioned already, I think we can do better. So I think some of those are the non-type 2 patients, oral steroid-dependent asthma, certainly, and then getting better improvement in terms of adherence for other inhaled therapies. And I think all that can result in better treatment for our patients. Lastly, I would say biomarkers. I think we're probably not as effective as we should be in terms of identifying biomarkers other than blood and sputum eosinophils, exhaled nitric oxide, and perhaps IgE. But I think we could do better in terms of identifying novel therapeutic targets and also novel biomarkers that can both predict responsiveness as well as identify response and correlate better with response to these therapies.
Yeah, I totally agree with you. I mean, there's that big unmet need for the type 2 low patient. Again, we all see still way too much oral cortical steroid use. So definitely there are unmet needs there. And I couldn't agree with you more related to the biomarkers. We need better genetic molecular biomarkers that really target better precision medicine in severe asthma. So hopefully a lot of that will be coming in the near future. So let's move on now and talk about airway hyperresponsiveness and epithelial inflammation, a renewed appreciation for their role in severe asthma. And I think some of the greatest work done over the last 10 to 15 years is really understanding the role of the airway epithelium. We really now understand how important it is, not only as far as a structural function and protection in that regard, but its role in both the innate and the adaptive immune system. And where a lot of this has in fact occurred is our understanding of when the epithelium does get bombarded, whether we talk about viruses or allergens or irritants, the upregulation of the epithelial alarmins, TSLP, IL-33, and IL-25, and how very importantly, they can not only trigger the adaptive immune system, where in fact they have an effect on the dendritic cells as far as activation of Th2 cells, which then leads to production of the type 2 cytokines like IL-4, IL-13, IL-5 and their role, but also through the innate immune system, especially effects on the type 2 innate lymphocyte with production of IL-13 and IL-5, and also effect on eosinophils and basophils. So by these epithelial alarmins, their effect as far as upregulation of type 2 cytokines, we get significant changes that occur to the epithelium. We get breakdown of many of the tight junction proteins that bind the epithelial cells together. We get goblet cell hyperplasia with increased mucin. The epithelium goes through an epithelial mesenchymal transition, where in fact we get increased production of collagen and fibrosis that in fact is occurring. So a great deal is occurring that we need to understand related to our asthma patients, related to the airway epithelium. Another very important concept is airway hyperresponsiveness. And it definitely is a hallmark symptom, something that, all the way back to when I was in medical school, but definitely a poorly understood component of asthma. What we do know for sure is that it does correlate with the severity in the patient. So it's thought that when we talk about airway changes that contribute to airway hyperreactivity, we have the structural changes, and we talked a little just about the epithelium just a minute ago, but we also have variable. We have the effects related to the underlying inflammation. And it appears to be a combination of these things that lead to the airway hyperreactivity. So we're all familiar with agents like methylcholine and histamine as far as a way of measuring airway hyperresponsiveness. And if we look at the graph over on the right, we can see the dose response curve. Again, looking at what levels of methylcholine or histamine that cause a 20% drop in the patient's FEV1. And obviously in the patients with severe asthma, it's very low levels compared to mild asthma and in normal. And if we look at this definition that Bussey gave us back in 2010, dissecting whether structural and inflammatory changes influence airway hyperreactivity will provide greater insight into this mechanism. Emerging data suggests that structural changes of the airway contribute to airway hyperreactivity, and that these structural changes include that remodeling and smooth muscle hypertrophy. And again, we've learned a great deal since 2010 here, breaking this down more and more, and we'll be covering more of this through this talk. So with that, Mike, do epithelial abnormalities contribute to airway hyperreactivity? And does any of this point to a potential clinical target for our patients with asthma?
I think it's pretty clear that the airway epithelium plays an important role in asthma. And I think from the data you've shown and that I'll be speaking about, it's clear that these epithelial cytokines in particular can play an important role in terms of mitigating airway hyperresponsiveness and activating a lot of the inflammatory and factors and inflammation that goes on in patients with asthma. So we're learning more and more about the airway epithelium. We're learning more and more about the epithelial cytokines, and we're learning more and more about airway hyperresponsiveness. And from the most recent data, it seems as if that these epithelial abnormalities really can contribute to airway hyperresponsiveness.
Yep, totally agree. It really is fascinating how much we have learned and how all this is, again, leading to better treatments for our patients. So I'll let you continue.
Great. So one of the things that we've started to gain knowledge about is the role that these epithelial alarmins play in asthma overall, as well as in airway hyperresponsiveness. And we've learned that there is production of these epithelial alarmins, including TSLP, or thymic stromal lymphopoietin, interleukin-33, and IL-25 as well. Those are the key epithelial cytokines. And they get activated by a variety of different stimuli, by noxious agents, including viruses, bacteria, allergens, cigarettes, smoke, and pollutants. They all get activated in response to these different stimuli. And these cytokines, IL-25, IL-33, and TSLP, they activate this adaptive immune response as well as an innate immune response. The adaptive immune response is involved in driving dendritic cell-mediated differentiation of Th2 cells, and that can lead to B-cell-dependent production of IgE. So upstream, these cytokines will cause Th2 activation that cause IL-4 production, that activate B cells that produce Ig, that act on the mast cells. Mast cells, as we all know, can degranulate and release histamines and be involved in the adaptive immune response and the allergic immune response. And in addition, alarmins like IL-25, IL-33, and TSLP can also elicit the innate immune response. And they can directly stimulate not just Th2 cells to produce IL-4, 5, and 13, but also innate lymphoid cells, or ILC2 cells, a relatively newly identified cell. In fact, they were initially called nuocytes. And they can also stimulate eosinophils directly, basophils, and mast cells. And when you get production and activation by these alarmins of Th2 cells and ILC2 cells, you get IL-4, IL-5, and 13 produced. And we've already talked about the role that IL-4 plays in terms of B cell production and activating IgE and producing IgE that acts on mast cells. But IL-5 is involved in eosinophil activation, production, as well as proliferation and maturation and degranulation. And eosinophils can release a variety of different mediators, including eosinophilic cationic protein, major basic protein, and others. On top of that, IL-13 is produced, which by Th2 cells and by ILC2 cells, and can cause airway hyperresponsiveness and also production of nitric oxide. So all of these factors are really downstream of these three alarmins, and we get activation of both the innate and adaptive immune response, resulting in allergic inflammation, eosinophilic inflammation, nitric oxide mediated inflammation, and also some degree of airway hyperresponsiveness as well. So let's dive in a bit more deeply into the roles that these different epithelial alarmins play. And we'll start off with TSLP, because I think we know more about TSLP than about any of the other epithelial cytokines. TSLP has been shown to drive elements of asthma pathophysiology, including airway hyperresponsiveness, and it's also involved in mucus production, in airway remodeling, and all of this occurs through effects that are triggered downstream. Again, because TSLP is upstream of IL-4, IL-5 and IL-13, it induces this broad inflammatory response that results in release of these key cytokines and can activate a variety of different cells, eosinophils, mast cells, basophils, and there's also a bit of an autocrine type of regulation of Th2 cells and ILC2 cells as well. There may be a role as well in terms of neutrophilic asthma, because we see that there's a lot of benefits of blocking TSLP in terms of patients who have non-eosinophilic, non-type 2 asthma. So that can be another important role as well. What about the other epithelial alarmins, IL-33 and IL-25? Well, both of these also play an important role upstream in terms of regulating a lot of the downstream inflammation that's going on in patients with asthma. IL-33 in particular is thought to act as a regulator of TSLP dendritic cell signaling, and it initiates and maintains Th2 cell-mediated inflammatory responses. It also plays a role in terms of driving airway hyperresponsiveness, again, thought to be due to interleukin-13-mediated mast cell airway smooth muscle crosstalk. And it also promotes mast cell survival, cytokine production, eosinophil survival, basophil activation, survival and proliferation, and increases IL-13 from ILC2 cells. It can also induce IL-5 and IL-13 in an IL-4 dependent and independent manner. And it can also enhance interferon gamma response as well, particularly in the presence of IL-12. IL-25 is the least well understood of all of these different alarmins. It is thought to play more of a role in allergic inflammation and may be driving type 2 inflammatory response during virally induced asthma exacerbations. And oftentimes, patients who've got high IL-25 have greater airway hyperresponsiveness, the potential for airway remodeling, and there's also increased blood and airway eosinophilia associated with it, in addition to elevated IgE. So now that we have these alarmins, I'm excited because we now have new therapies that can target some of these alarmins. And the most recent development in asthma, and I would say probably the greatest development in the last year or two, is the development of Tezepelumab, which is a monoclonal antibody that targets TSLP. It was just approved in December of 2021, so about 7 or 8 months ago, and it was approved for add-on maintenance treatment for patients with severe asthma, broadly of patients with severe asthma, age 12 and up. It's a safe therapy with an adverse effect profile similar to placebo. Now, this was approved, Tezepelumab was approved based on a few different studies, including a phase 2 study called the Pathway trial, in which Tezepelumab, given at 3 different doses, was shown to reduce asthma exacerbation versus placebo. Here you can see the 3 different doses on the right-hand side in the green, 70 milligrams every 4 weeks, in the blue, 210 milligrams every 4 weeks, and in the red, 280 milligrams every 2 weeks. All 3 of these doses substantially reduced exacerbations on the order of 62 to 71%. So this was really exciting because of the magnitude of reduction. But what was more exciting to me was to see the broad efficacy, broad group of patients, independent of eosinophil count, independent of nitric oxide count, and independent of Th2 status. As can be seen here from this Pathway study that was published by Jonathan Corn a few years ago in the New England Journal of Medicine, patients responded to Tezepelumab whether they had high eosinophils at baseline greater than 250 or less than 250, high nitric oxide greater than 24 parts per billion or less than 24 parts per billion, and whether or not they had a high Th2 status or low Th2 status. Across the board, there was significant reduction in exacerbations in all of these patients. This led to the phase 3 Navigator study. And here again, there was a lot of excitement and enthusiasm because again, there was robust reduction of exacerbations in patients independent of baseline biomarker status. In the overall population, and again, there were a large group of patients, over 1,000 patients were studied, compared to placebo, there was a 56% reduction in exacerbations. But most importantly, as you can see from this forest plot, in all groups studied, high eosinophils, low eosinophils, all the different strata of eosinophils. What was the most exciting to me was the less than 150 eosinophil group, where we've yet to see broad efficacy as is demonstrated here. And we saw almost a 40% reduction in exacerbations in patients with less than 150 eosinophils. So that was really exciting because we don't have any therapies to compete in that sphere to that degree. Same thing with low nitric oxide. Less than 25 parts per billion, there was a reduction in exacerbations and across all strata, and also independent of allergic status. In this forest plot, when you look at the line in the middle, you can see that's the rate ratio that favors either placebo or favors Tezepelumab. And in all these different strata, there is significant favoring of Tezepelumab. In addition to the reduction in exacerbations in the study, the Navigator study published by Andrew Menzies-Gow in New England Journal of Medicine just a year ago, you can see that there was also an early improvement in lung function in FEV1. And that early improvement compared to placebo was sustained over the 52 weeks of the study. So that too is exciting to me, that not only was there an early improvement that was robust and over 150 cc different compared to baseline on top of combination inhaled corticosteroids and long-acting beta agonists, but that it was sustained over the 52 weeks of the study. And there was also significant improvement in a variety of different patient-reported measures of asthma control. The Asthma Control Questionnaire 6, again, you can see that there's an improvement compared to placebo, the Asthma Quality of Life Questionnaire, and as well the asthma symptom diary scores. All of these were improved compared to placebo. All this is I'd say, significantly important. Now, one of the, I would say, studies that didn't fare as well was this study that we published actually this year in the Lancet Respiratory called the SOURCE study. This was a study in patients who were on oral corticosteroids. And the goal was to evaluate the oral corticosteroid sparing effect of Tezepelumab compared to placebo. So these were all oral steroid-dependent patients, and patients were administered Tezepelumab 210 milligrams every 4 weeks with a goal of reducing corticosteroid dosing. Unfortunately, in the overall population, there wasn't a significant reduction in corticosteroid dosing. While 53% of patients were able to reduce their corticosteroids completely, 90 to 100% reduction in steroids with Tezepelumab, about 46 to 47% of patients on placebo were also able to reduce corticosteroids. That being said, when you break down this patient population based on eosinophil counts, you can see that in patients who had eosinophilic asthma who were on oral corticosteroids, there was a reduction in exacerbations in that patient population, as long as they had more than 150 or more than 300 eosinophils. So we think that this failure in this study in the overall population was due to a dramatic placebo response. And it is important to recognize that while steroid reduction did not necessarily fare as well with the Tezepelumab group compared to placebo, other outcomes did do better, including reduction in exacerbations in oral steroid-dependent patients, improved FEV1, and improvement in a variety of other patient-reported metrics. So we have now, I'm so excited because we have 6 therapies available for treatment of patients with severe asthma. And these have been shown to have broad efficacy in a broad group of patients. We have therapies ranging from ones that target TSLP, the epithelial alarmin, which is upstream, blocking IL-4, 5, and 13, and has been shown to reduce nitric oxide, IgE levels, and blood and sputum eosinophil counts. We've got Dupilumab, again, another important biologic therapy that blocks IL-4 and at the IL-4 receptor. And this has been shown to reduce nitric oxide and IgE. While the eosinophils with Dupilumab go up, we believe this is due to the fact that blocking IL-4 and 13 reduces eosinophil trafficking from the blood into the tissue, so eosinophil levels can stay high. But they stay out of the tissue, which is important. Omalizumab lowers exhaled nitric oxide, It also lowers free IgE levels, although it has minimal effect on blood and sputum eosinophils. And then the three anti-IL-5 therapies, mepolizumab, reslizumab, and benralizumab, they have significant benefit in terms of reducing blood and sputum eosinophils, although they don't work as broadly, and they don't have significant benefit in terms of nitric oxide and IgE levels. One of the other benefits of tezepelumab is its impact in terms of improving airway hyperresponsiveness. And Mike already talked to you about the importance of evaluating airway hyperresponsiveness in patients with severe asthma. Airway hyperresponsiveness, or the twitchiness of the airways in patients with severe asthma, can be an important symptom in patients, or can result in coughing, chest tightness, wheezing in patients with severe asthma. And with tezepelumab, it's been shown that there's a significant improvement in terms of reduction of airway hyperresponsiveness in patients treated with tezepelumab compared to placebo. In this Mannitol study, you can see that there's a benefit of tezepelumab improving the mean doubling doses doubling doses in response to a challenge. But in terms of improving the PD15, improving FEV1 in our patients, there's significant benefit of tezepelumab, and the greater proportion of patients had improvement in airway hyperresponse with tezepelumab compared to placebo. Another important factor was from the Cascade study, which was published by Diver last year in the Lancet Respiratory, where it was shown that tezepelumab was the first therapy to block tissue eosinophils. So on biopsies, it was shown that you can improve tissue eosinophils. There are a few other therapies that are targeting some of the alarmins, not just anti-TSLP therapy with tezepelumab, but itepekimab is an anti-IL-33 therapy that has been shown to be effective in terms of patients with severe asthma. This was a study that we published in the New England Journal of Medicine last year and demonstrated broad efficacy in a phase 2 study comparable to dupilumab. But what it was interesting, in combination with dupilumab, there was no significant benefit compared to either itepekimab or dupilumab alone. A few other therapies target IL-33 as well: itolizumab, astegolimab, and tozorakimab. Try saying that on a Saturday morning. Well, all three of those therapies target either IL-33 or the IL-33 receptor, ST2, and they've been shown to improve outcomes in patients with severe asthma as well, particularly patients with severe eosinophilic asthma. The astegolimab improved outcomes and reduced exacerbations also in patients who had low eosinophilic asthma, and they all seem to be relatively safe. The tozorakimab study is an ongoing study that has shown some degree of efficacy and safety in adults with moderate severe asthma. So we've gone through a lot of monoclonal antibodies just now. Again, these are really exciting times. Mike, tell me, what's your impression of the role of anti-TSLP, tezepelumab, as well as the other potential alarmin therapies in current asthma management?
Well, I think what you've demonstrated, and especially from your data with anti-TSLP, is the broad efficacy of this particular agent, not only the type 2 high patients, but very importantly, that group where we've lacked excellent treatment, and that being the type 2 low patients. So I think this has really opened up a great treatment for so many of our patients that have not qualified for other biologics that have been approved, in fact, in the past. And I think it's very interesting to be looking at the other epithelial alarmins, as you mentioned, especially some of the preliminary data with some of the anti-33 agents. There are mouse studies with anti-25. We'll see if any human studies ever come about associated with it, and whether maybe a combination of these agents work better for certain patients. But it really does open up a whole new way of treating so many of our patients that in fact it may not have responded as well to products that we presently had on the market.
Yeah, as you said, if we think back to the beginning of our discussion, we talked about some of the unmet needs, and I think blocking TSLP and the other alarmins addresses many of those unmet needs, including the non-type 2 asthmatics, the airway hyperresponsiveness, and they also might have the potential to abrogate airway remodeling, which can be an important contributor to refractory asthma patients. So I'm excited that we have all of these novel therapies. So one of the things that comes up is, how do you manage your patients with biologic therapy, and how do you evaluate when to start, when to stop these therapies? The starting piece is relatively easy. We look for patients who are poorly controlled on inhaled steroids and long-acting beta agonists. But how do you evaluate your patients after initiation? And the GINA guidelines, the Global Initiative for Asthma guidelines, really come out strongly in terms of making some recommendations that you need to constantly reevaluate your patients even after you start a biologic therapy. Evaluate your patients after 3, 4, 5, 6 months and evaluate whether or not they're responding. If it's clear that they're not responding, then you should consider stopping the biologic or switching to a different class of therapy. You also should consider reviewing, going back to the basics and evaluating, does the patient have some comorbidities that could be still contributing? Also, could the patient be aspirating? So you should do things like evaluating patients' airways by chest CT. And if a patient isn't responding, maybe also reevaluate biomarkers. Perhaps you're blocking IL-5 and the patient still has high nitric oxide levels. Does the patient have some other mechanism of disease? And if the patient isn't responding, then you should stop the ineffective add-on therapy. You should always continue the inhaled corticosteroids, however, and that's really, really important. The other concept is that if the patient is doing well, and after your 3 to 6 month evaluation, then you should really try to decide, well, what to do next in terms of how to approach their management. Really, you should consider maybe decreasing doses of inhaled corticosteroids, or maybe even discontinuing some components. If patients are on long-acting muscarinic agents and they're doing well, you could consider tapering those therapies off. Certainly, if a patient's on oral corticosteroids, and which are associated with such significant side effects, cataracts, glaucoma, osteoporosis, weight gain, and all the other side effects associated with corticosteroids, you should begin to taper corticosteroids in those patients. You should always reevaluate the need for ongoing biologic therapy and think about shared decision-making with your patient about the benefits versus the risks of all these therapies, also evaluating the cost and also figuring out patients' preferences in terms of dosing strategy, dosing frequency, and all of the other important outcomes that we think about in asthma. Now, one of the things that we've learned, however, from the Chronicle study is that even though we know that the reduction in exacerbations is about 50 to 60% for most of these biologic therapies, once you start a patient on a biologic therapy, most people continue them. And the Chronicle study highlighted the fact that over 90% of patients treated with biologics continued them, even if they weren't working so well. So now we've got a lot of different options. We have 6 different biologic therapies available. So if your patient isn't responding to a specific therapy, at that point, you should probably consider discontinuing, switching, and considering alternate approaches for their asthma management. So we've had a great discussion so far. We're going to move on in a moment to review a few cases. But just to summarize what we've talked about today, asthma remains a big problem. There are over 25 million asthmatics out there, many of whom have severe disease. And we are recognizing and learning more and more about the pathophysiology of asthma, that asthma is heterogeneous. There are many different pathways that are involved. There's allergic asthma, there's eosinophilic asthma, there's non-type 2 mediated asthma, and all of these can result in the presentation of asthma symptoms, whether it's cough, chest tightness, exacerbations, wheezing, all of which can be resulting from all these different factors. And despite the fact that we have good therapies, both inhaled and biologic therapies, many patients continue to have symptoms, many patients continue to have exacerbations. So there still remains an unmet need. The key strategies to approach these patients are really to figure out what type of asthma does this patient have. And you want to phenotype your patients. You want to evaluate biomarkers, including eosinophils, nitric oxide, IgE levels, and utilize all the tools that we have in our toolbox to approach our patients with asthma, whether it's targeting IgE, IL-5, the IL-4 receptor, or targeting TSLP currently. And maybe in the future we'll have other therapies and strategies that work as well. But we have this broad range of therapies that are available, and they really have been shown to have a significant impact in terms of reducing exacerbations, improving lung function, improving quality of life, and having an overall meaningful effect in terms of also reducing corticosteroids. So let's take a look at a couple of different studies. Mike, do you want to go ahead and present the first case study?
Sure. So let's do case study 1. We can have the next slide. So here we have Lou, a 42-year-old male, and he presents to your office for a routine follow-up 8 months after initiating and on anti-IL-5 therapy for his severe asthma. So if we go through his medical history, he was diagnosed with asthma at 28 years of age, has a history of chronic allergic rhinitis with positive testing to both house dust mite and mold. His asthma worsened over the past 8 years and was uncontrolled despite high-dose inhaled corticosteroid, long-acting beta agonist, and tiotropium. So he was assessed for biologic response at 4 months. As we'll see, the response, in fact, was unclear. So what's he currently on? We mentioned he's on an anti-IL-5 therapy at home, sub-Q every 4 weeks. Medium dose inhaled corticosteroid because they tried to step down his dose from high when he was started after 4 months of the anti-IL-5 therapy. He's also on a leukotriene receptor antagonist, and a short-acting beta agonist is needed. Next slide. So what do we find on physical exam? He has a normal BMI. HENT definitely shows allergic rhinitis with his turbinates pale and swollen, but no polyps seen. On chest, his lungs were clear. And then his baseline lab results showed an elevated IgE of 264, elevated specific IgE to house dust mite at 37 international units, an elevated ENO of 68 parts per billion, elevated blood eosinophils of 360 per microliter, and his lung function showed 66% of predicted pre-bronchal dilator. Given a bronchodilator, he showed 13% reversibility. So let's compare his baseline symptoms to what they are currently after treatment with the anti-IL-5 therapy. So if we look at symptoms at baseline, he was having them about 3 times a week and multiple times per day, once a week. Now, they did drop to twice a week with multiple times, about 1 time a week. Interference with activity, no real change. He still has some limitation. He did have a decrease in exacerbations requiring oral corticosteroid. He went from 4 in the previous year with 2 severe down to 2 in the last 8 months. Nighttime awakenings improved from 3 to 1. And then his asthma control test did improve from 15 to 17, though that's still not control. As we know, control would be 19 or greater. So when we talk to Lou, he tells us he does feel better, but he still worries about his asthma, that it's interfering with his goals to stay fit. He's partially satisfied with his current treatment plan, but he's not 100% there. So this leads to our first polling question for you. Based on the information I've given, do you think this is an adequate response for Lou? Is it yes? No? It's tough to tell. I need more information. It's up to Lou if this is the response he's after. So let's see your results. Okay, so the biggest number is no, 73%, followed by it's tough to tell and I need more information. We'll go over some in just a minute. And 9%, in fact, said yes, but no one said it was up to Lou and his response. Any of these answers may, in fact, be correct, and even D, as we get to shared decision making, because obviously Lou's responses is extremely important also. Next slide. Okay, so let's see what happened to his lab. Here's some more information for us. His total IG basically stayed the same on the anti-IL-5. His ENO stayed the same from 68 to 66. He did show a drop in blood eosinophils from 360 to 66. And his lung function basically had no significant change. 66% are predicted with 13% variability at baseline, went up to 68% with 11% reversibility. So not a great deal there. So this gets back to shared decision making, because we really do need Lou's input here, and then determining what would be the next step for him. So all options were discussed, and that's important: the pros, the cons, the outcomes, the cost, and the findings from his exam and lab results were reviewed and increased his inhaled corticosteroid. And the decision was made to initiate a trial with another biologic with the hope of a greater response. Next slide. So what would you do then? Add on as far as Lou's add-on biologic. Would you switch to a different anti-IL-5, 5R, or an anti-IgE, or an anti-IL-4R, or an anti-TSLP? So here comes the polling question. If we could have your answers, please. Okay, so we have the highest number, about 50%, were anti-TSLP, followed very closely by anti-IL-4R biologic at 43%, small percent, 7% anti-IgE. No one wanted to switch the patient to a different IL-5, 5R. So if we go to the next slide, basically, any of the treatments, in fact, even if you think about it, you could try another anti-IL-5, could be, talk to Lou related to shared decision making, because he does still fit criteria, at least definitely for these three agents. Again, his blood eosinophils did drop with his use of the anti-IL-5, though he did not show significant clinical improvement. So we have either anti-IgE or anti-IL-4, anti-TSLP. So all of these, as it says here, are reasonable choices for a switch for Lou. And I think, again, this is where cost, shared decision-making make a big difference.
I think, Mike, we have to again ask, what type of asthma does he have? And he has type 2 asthma broadly. He's got high eosinophils at baseline, high nitric oxide, high IgE levels. And I think all three of these would be reasonably targeted by these different biologic therapies. You tried anti-IL-5, he got some improvement, but he didn't get the complete improvement that he was looking for. And so maybe I think that's the time to consider switching if he doesn't get the response that you're looking for overall. And I think that's an important component. So let's move on to case number 2. So the first case that we discussed was a patient who had type 2 disease, who had incomplete response to anti-IL-5 therapy, and we should consider switching. Let's see what kind of patient we have in type 2. This is Beth, who's a 38-year-old female with late onset asthma. And she comes in for a follow-up of her asthma, complaining of recurrent viral infections that exacerbate her asthma. She reports the past medical history of asthma that started 3 years ago at age 35. So she's got adult onset asthma and followed the onset of daytime asthma symptoms and an exacerbation requiring hospital admission. She says this was all triggered by smoke from a wildfire. She's a former smoker, and she's got a 17-pack-year history, and she quit after a diagnosis with nicotine replacement therapy and bupropion. She's also got a history of hypertension. She's got some mild obesity with a BMI of 30, and she's on high-dose inhaled steroid and LABA. She's on ASNI, short-acting beta agonist, and she takes lisinopril for her high blood pressure. She comes in reporting symptoms 3 to 4 times a week, and she has symptoms multiple times a day, twice a week, is significant interference with her daily activities, and she has exacerbations requiring oral corticosteroids. She's got nighttime awakenings twice a month, and her asthma control test score showed that she had a score of 14, which suggests that she's poorly controlled. She reports adherence to medication. She demonstrates good inhaler technique, and it's really important to evaluate those things in all of your patients because if someone is poorly controlled, it's because they're not taking their medication, because they're not taking their medications properly. But she shows that she's doing that. And despite the fact that she's taking her inhalers, despite the fact that she's got good inhaler technique, she continues to have these symptoms. And she's also shown some partial response of her exacerbations to oral corticosteroids. And this should give you a clue that perhaps there's something more than just type 2 asthma going on, because many patients will have much better response to oral corticosteroids. So in looking at her biomarkers, you see that her Ig level is very low. It's 7.5, suggesting that she doesn't have a strong allergic component. Her nitric oxide level is 16 parts per billion, again suggesting that she is unlikely to have IL-13 mediated asthma. And her blood eosinophils are 78 cells per microliter, suggesting that she also doesn't have a significant eosinophilic type 2 component. Overall, when you ask what type of asthma does she have, you'd say, well, she's got non-type 2 disease, and she's got severe disease based on her symptoms, and that's poorly controlled with a low lung function of 65%. So you'd categorize her as type 2 low or non-type 2 severe asthma. So what would be your next step with Beth? Would you add on tiotropium? Would you add on azithromycin? Would you add on azithromycin and tiotropium? Would you put her on a low-dose oral corticosteroid? Or would you add on a specific biologic therapy? Please go ahead and answer. Okay, so really interesting results here. So broad range of responses, as would be expected. I don't think any of these strategies are wrong. Tiotropium has been shown to reduce exacerbations and improve lung function. Azithromycin, when given 3 times a week, has been shown to reduce exacerbations in patients with type 2 high and type 2 low asthma. Some of you said you do both of these strategies, both add-on azithromycin and tiotropium, which I think is an appropriate response. Adding on low-dose oral corticosteroids can help over the short term, but may be associated with other side effects. So I'd be cautious about using low-dose oral corticosteroids. And in terms of adding on a biologic therapy, really the only one that I would consider would be anti-TSLP therapy, Tezepelumab, because she's got non-type 2 disease. And you're not going to be effective in terms of targeting IgE in her. You're not going to be effective in terms of targeting eosinophils and IL-5, or eosinophils were low. You're not going to be effective in terms of targeting IL-4 and 13 because both her eosinophils and her nitric oxide are low. So the only biologic therapy that I'd consider would be anti-TSLP therapy with Tezepelumab. So Beth gets started on tiotropium and azithromycin, in addition to her high-dose inhaled steroids, because that's what most people want her to do. And her symptoms improve for about a month, But then she had another exacerbation and she had to go in. She had acute care. She was given another dose of corticosteroids just a month after discontinuing the azithromycin that had previously been started. And so here you've got a patient with non-type 2 disease who's refractory to some of the standard of care therapies that we have. So what would you do next? Would you discuss long-term antibiotic use in her? Would you add on a low-dose oral corticosteroid? Would you add on a biologic therapy? Or would you consider bronchial thermoplasty, another important option? Bronchial thermoplasty, for those of you unfamiliar, is an FDA-approved procedure that involves delivering heat or thermal energy to the airways to abrogate airway smooth muscle and results in a reduction in exacerbations. Let's take another moment. Okay. So let's see what people said. One of you said you discussed long-term antibiotic use. So maybe the course of antibiotics wasn't sufficient for her. So that's one option. Adding on low-dose oral corticosteroids was chosen by nobody, and I think that's appropriate given the fact of that she didn't respond as well to oral corticosteroids in the past. Adding on a biologic therapy such as Tezepelumab, which blocks TSLP, is effective in patients who've got non-type 2 asthma. And bronchial thermoplasty would also be another important consideration that I think is a reasonable choice. Again, it reduces exacerbations by about 50%. That gets sustained out to about 5 years in patients with severe asthma. So I think those are reasonable choices. I would probably start her on a biologic, while I would think about giving her bronchial thermoplasty is what I would do in my practice if I saw this woman. So let's take a quick look at all these different options. Macrolide antibiotics have been shown to have efficacy in patients with severe asthma, reduction of exacerbations by about 40 to 50%, but there are concerns about long-term resistance to these antibiotics and really should be used for patients with the highest risk of exacerbation. Low-dose oral corticosteroids, again, we said they work broadly, but they're associated with significant toxicity and adverse effects, and she hasn't really responded to these completely in the past, so that would be unlikely to be effective. Biologics, anti-TSLP therapy has been shown to be effective in type 2 low asthma, and it works independent of blood eosinophil count, so that would be a very reasonable option. And bronchial thermoplasty, again, is a bronchoscopic procedure that targets the smooth muscle by delivering heat. And it's been shown to have modest clinical benefit in patients with asthma. It reduces exacerbations by about 50% with sustained reduction out to about 5 years. So we've had a great discussion today. Mike, I want to thank you for participating. Let's see if the audience has any questions that they have. You can either unmute yourself or go into the chat and put in to see if, and we'd be happy to spend a few moments answering questions. Okay, I see a question's come up in the chat. No, nothing yet. Take your time. We've got a few minutes. Thank you guys all so much for participating today. I know it's a Saturday morning. People want to get out and be with the family. So I'll just summarize while people think, put their thoughts together. Again, these are really exciting times for the management of asthma. We've learned a lot about the pathophysiology and the heterogeneity of asthma. We've learned a lot about the role the epithelium plays about asthma with regard to being upstream of all the inflammatory responses. The epithelial cytokines, IL-25, IL-33, and TSLP are relatively novel targets that really can benefit patients with severe asthma, both type 2 and non-type 2 asthma, and can also ameliorate airway hyperresponsiveness as well. So I'm really excited that we have all these different options. Mike, any last parting words from you?
No, I think all of that is great. We did get a quick question. I'll just quickly. Question was, any anaphylaxis or hypersensitivity reported after administration? I think we all know that omalizumab has had a warning related to anaphylaxis, though I think after 17 years of use, we found that to be extremely rare. As far as all the other biologics, including the latest data with Tezepelumab, it seems that anaphylactic reactions to these agents are also very extremely rare, which is why for so many of them, home administration has been approved.
Yeah, great point. I feel pretty confident using all these biologics, including omalizumab for my patients. I think the risk of anaphylaxis is relatively low, even in the omalizumab patients, and really not really seeing all the other biologic therapies. All right, if there's no more questions, why don't we close out our session? I want to thank Mike Blaiss, my colleague, for a great discussion, great presentation this morning. And I want to remind you all to complete the post-test and evaluation by either scanning the QR code or going to integrityce.com/SA post-eval5. And I want to thank you all for attending today's program. Thank you so much for attending. It's great to have you, and we look forward to future CME programs. And I also want to thank our colleagues at Integrity Continuing Education for helping us develop this program in conjunction with sponsorship from AstraZeneca. Thank you so much all for your attention today. It's great to have you, and thank you again for participating.
Thank you, and enjoy your weekend.